Next question, patient sustains a full thickness tear of the teres minor. Which of the following tests would most likely be positive in this patient? So here we're looking, you need to know specifically what the importance of the teres minor is, and the correct answer is the Hornblower test. The teres minor is an important external rotator of the shoulder, and it's more biomechanically relevant with the arm elevated. So external rotation with the arm to the side is traditionally felt to be mostly infraspinatus. External rotation strength with the arm abducted and externally rotated is definitely mostly teres minor. We're going to move on to shoulder exam now. We're going to break down this topic into some elements of the general shoulder exam and also impingement and rotator cuff tests. You'll hear more about the other elements of the physical exam in some of the other webinars. In general, one important thing to remember about the shoulder physical exam, it's important to disrobe the patient and really look at their skin, look for scars, look for asymmetry, which can indicate swelling or muscle atrophy. And most importantly, when you're doing a physical exam, really look at their, when you're assessing their range of motion, look for scapular dyskinesia or evidence of scapular winging. Those can be a very important, a subtle finding that can be a very important part of the patient's pathology. You can see scapular winging in patients, for example, with multidirectional instability. And also you can see some scapular dyskinesia or weakness in patients with chronic rotator cuff disease, and it can actually predispose them to having rotator cuff pathology. So scapular winging must be identified, and you want to make it a part of your treatment algorithm. In terms of palpation, palpation is actually very important in the shoulder exam. Palpation and localizing of pain. Classic pain across the top of the shoulder is usually related to the AC joint. Rotator cuff pain is usually seen at the greater tuberosity and radiates down the lateral or anterior arm. In biceps groove or glenohumeral arthritis pain is usually deep anterior with minimal radiation. Sometimes the biceps can radiate down the arm. So it's important to remember to palpate on your physical exam. Palpate the greater tuberosity, the acromion, the AC joint. They can clue you into the pain generators. Range of motion exam is critical in the shoulder. You want to look at both active and passive range of motion and try to compare it to the opposite side. I would start with active range of motion initially, and if that's normal, you really don't have to check passive motion. But if there's a limit to active motion, you don't know if it's weakness or stiffness, so you have to kind of follow up with passive range of motion exam. The 6 cardinal motions that we look at are forward elevation, usually flexion and scapular plane abduction, external rotation with the arm at the side, external rotation with the arm at 90 degrees abduction, internal rotation behind the back, and internal rotation at 90 degrees of abduction. And each of these physical exam range of motion tests gives you a little bit more different information about what's possibly causing the patient's symptoms. We'll go into the range of motion exam a little bit more in a second. Every good shoulder exam should have a detailed neurovascular assessment. So neurovascular exams includes assessment of sensation, motor exam, vascular, and then special tests. So the motor exam, it's really important to look at all of these cervical myotomes. C5 is classically deltoid and biceps. C6 is classically wrist extension and brachioradialis. Triceps is classically C7. EPL, or extensor pollicis longus, is classically C8. And the first dorsal interosseous or the dorsal interossei, classically T1. You want to make sure you screen through all of those quickly in patients, especially if they have symptoms below the shoulder, below the elbow level. So if you see an exam question that somebody has shoulder pain, but they also have fairly significant medial scapular pain or symptoms below the elbow, you've really got to take a close look at the neck. Special tests at the neck are really important. The Sperling maneuver, where you extend the cervical spine and rotate towards the involved side. If that elicits symptoms down the arm, specifically below the elbow, you need to focus your imaging studies on the cervical spine. Other things to look out for are suprascapular neuropathy and brachial neuritis, which is fairly uncommon, but at least something you should keep in your differential diagnosis. Some of the special tests that we do in the shoulder exam, this is the near impingement sign, and it's indicative of basically inflammation in the rotator cuff tendons and the subacromial bursa. We're all kind of familiar with this test, but it's important to kind of review how to do it correctly. So basically, the examiner is standing to the side of the patient. Their hand is on the scapula. They take their arm into forward elevation, and they basically stabilize the scapula and try to push forward into elevation. This can be augmented with some internal rotation torque at the shoulder, but pain is elicited along the anterolateral acromion radiating down towards the deltoid in the mid-arc of elevation. So you must have full range of motion for this test to be considered positive. The near impingement test is different from the impingement sign, and this is basically if you get a positive impingement sign, you can inject the subacromial space with local anesthetic and then re-examine the patient 5 to 10 minutes later. If they have significant reduction of pain, you know the pain is coming from the subacromial bursa. A Hawkins test is another classic test for look for subacromial impingement. The shoulder is flexed 90 to 100 degrees, and you want to basically internally rotate and augment that internal rotation. Here, what's happening is the greater tuberosity is being pinched, is pinching the bursa under the coracoacromial arch. So pain, again, along the cuff distribution is a classic, considered a positive Hawkins test. So all these tests are used in conjunction to help figure out if this is a cuff-based pain or not. The Jobes test is classically designed for supraspinatus strength, and I'm not sure if it's a great impingement test or not, but basically you want to abduct the arm to about 90 degrees in the plane of the scapula. I'm lost my screen again. You want to internally rotate the shoulder and then resist elevation, basically. So you're looking for the presence of pain and weakness in the cuff distribution. I think the Jobes test is probably a little bit more reliable sign of possibly rotator cuff tear versus impingement. You can have impingement sign and still have a negative Jobes test. Impingement pain and still have a negative Jobes test, and vice versa. Internal impingement is a completely different phenomenon. This is pain that's brought on with the arm in the cocked position. So basically abduction of 90 degrees and external rotation 90 degrees. And this comes from mechanical impingement of the greater tuberosity and the undersurface of the cuff against the posterior superior glenoid. So this is not a subacromial impingement process. This is an internal impingement process. If the test is an internal impingement sign or test is positive when you bring them up to the arm cocked position, if it reproduces pain not radiating down the cuff distribution but very sharp and located deep in the posterior shoulder, if you bring their arm in horizontal adduction from that point and it relieves the pain, and then you externally rotate them from that position and the pain stays reduced, that's considered a positive test. Other tests for the rotator cuff, when you're looking at subscapularis strength, you don't want to test this as isolated internal rotation with the arm to the side because of the contribution of the other internal rotators, specifically the pec and the latissimus. This internal rotation lag sign, I don't use this very often clinically, but it is very accurate if you get a positive test. And one of the downsides of this test is you have to have really good range of motion just to get into the test position. But basically, if you bring the patient's hand behind their back into the small of the back with their elbow flexed about 90 degrees and bring their hand away from the small of their back and into a maximum internal rotated position, and then you have them hold that position. If they can hold it and generate some resistance into your hand, if that's negative, that's a pretty good sign that the subscapularis tendon is intact. They have to have really good passive motion to interpret this as a true positive, though. So not everybody has the available range of motion to get there. Other signs of a subscapularis deficient shoulder is increased passive external rotation and a liftoff test. Liftoff test is classically performed by having the patient try to reach behind their back into their sacrum. It's similar to the last test I described, but they're starting with their hand actually against the sacrum, and they try to push their hand off of the sacrum and hold that against resistance. That's felt to be a more accurate test for the inferior aspect of the subscapularis. The belly press test is considered more accurate for the upper portion of the subscapularis, and basically this is done with the hand in front of them on the abdomen. They bring their wrist into a neutral position so that their elbow moves forward out of the coronal plane, and then you have them press into the abdomen and see if they can hold that position. What you're looking for is either extension of the elbow or wrist flexion, and if failure to hold that position can be a sign of subscapularis insufficiency. The take-home point with all of these subscapularis tests is none of them you can hang your hat on completely. Each of the tests requires fairly good passive range of motion. Each of the tests seems to examine a slightly different portion of the subscapularis muscle. So this is just one part of your total assessment for the patient. You get other clues based on x-rays and advanced imaging as well. We usually assess supraspinatus strength and Job's position as we talked about earlier. Again, the arm is abducted in the plane of the scapula, 90 degrees, slight internal rotation, and then you resist elevation. That's a reasonable test. I will tell you that patients that have a lot of pain in their shoulder, whether it's a painful partial tear or tendonitis with acute subacromial inflammation, they can have weakness on that test. So pain can inhibit muscle function. You can't hang your hat entirely on weakness as being a sign of rotator cuff pathology. So usually advanced imaging is required. Let's move on. A drop sign is a sign that has actually fairly good accuracy for larger rotator cuff tears. So basically you take the arm and elevate them into the plane of the scapula 90 degrees, ask the patient to hold and then lower slightly from that position. If they cannot hold that position where it drops quickly, that's usually indicative of a fairly large tear. It's definitely not isolated to the supraspinatus tendon. Usually that's going to be a combined supraspinatus and infraspinatus tear. The infraspinatus strength is best measured with resisted external rotation with the arm at the side. You want to have them in slight internal rotation. Again, you're looking for pain and weakness. External rotation lag signs are very helpful clinically, and basically when you take the patient into with their arm at the side, if you passively externally rotate them to the maximum position and have them hold it, a positive lag sign is when they cannot hold that position. And you want to do this both with the arm at the side and in Hornblower's position to determine if this is just supra-infra tear or supra-infra and teres minor involvement as well.
If you enjoyed this video, please consider leaving a like. We'd love to hear your thoughts and what you'd like to see next in the comments. Don't forget to subscribe to our channel and follow us on social media.